Hi guys, Rishad here. Hope you all are ready for the battle. Yeah, just 2-3 days left to go. Hope you all are geared up, ready to blast the exam. Okay, yeah, I'm making this video to notify you guys the mistakes you're doing. Like I have happened to correct some of your mocks, and many of you guys are repeating the same mistakes, even though we have been telling you repeatedly in during the course and later on as well on WhatsApp group to avoid making those mistakes. So regard this video as a last minute tips of how to answer appropriately in the exam. Okay, just follow me guys. In this video I'm going to talk about the mistakes what I had done and what I jotted down on the paper, and I think majority of you guys are doing the same mistakes. Okay, so let's get started. In the video and in the end of the video, I'm going to give you a checklist of the common things which are being asked in the exam. So regard that as a checklist and just these 2-3 days, just go through the checklist and see whether you have read those things or not. Okay, so let's get started. Okay. What we found during the course and during like correcting your mock exams, many of your people are making mistakes in the management questions. People are not sure what to write in management. So in the next slide, in the coming slides, I will talk about how to approach the management questions. Okay. The next mistake we found is the word next. Whenever you see the word next, and these are the questions which are very specific, they want to see what you are going to do next. That means it is immediate next thing you're going to do. And also there is a difference between next step and next management. Next step is one single thing what you're going to do. Okay, next management means 2-3 things you can write over there. So be careful. The whenever you see the word next, you have to be specific. Okay, and also whenever you see the word next, you have to see in the scenario what has already been done to the patient. For example, as you guys know, all emergency physicians do this ABCD approach, but you cannot write ABCD approach on the paper. Okay, like for example, what I was giving is in the scenario if airway is taken care of, breathing is taken care of, and when they are the work when they ask what is your next management, you cannot write again airway. I would put like for example I would put oxygen, I would check like his patency and all, because the scenario is already saying that airway and breathing has been taken care of, so your next would be circulation. Okay, and never, please never write A B C D E approach. Just write as if you're writing on your case sheet. Do you guys write A B C D in your case sheet? No, right? A B C D is just for you to know the approach. Just write as if you're going to write in the case sheet, like oxygen, how much oxygen you want via which mask. Write that. Okay, and even I don't want you guys to write in circulation, I don't want you guys to write IV fluids. What are IV fluids? Write intravenous fluids. What fluid you want to give? 0.9% normal saline. Okay, please be specific how much you want to give. 500 ml, 250 ml. Write that. And remember, all fluid overload patients or heart failure patients with shock, please mention the word judicious fluid resuscitation. That is the word they're looking for. Okay. Okay, next the picture question. Majority of you guys are missing on picture questions. Okay. Let's talk about it in my next slide, like how to correct those. I think many of you have given this exam previously and you were confident of the answers. Some of the answers you were confident and you expected to get 3 out of 3 in those answers, but in your feedback you either got a 0 or 1. That really annoyed you, right? So I will tell you what mistakes we are doing in that. See, for example, there was a question of winging of scapula last time, I think in March diet. So, in the Mars diet, when I approached the question of winging of scapula, the first question was, "What is your diagnosis?" There's a photo. There was a photograph of winging of scapula. The first question was, "What was the diagnosis?" I wrote winging of scapula. I was very happy. Next question was, "What is the muscle involved?" I wrote serratus anterior. I was like, damn proud of myself. The third question was, "What is the nerve involved?" I wrote long thoracic nerve. I was so happy that I thought I nailed the question and I have to get 3 out of 3. But unfortunately, I failed that exam, and in my feedback, when I saw, I got 1.5. You know why I got 1.5? Because I forgot to write the side of winging of scapula. The answer should have been right winging of scapula, right serratus anterior, and right long thoracic nerve. This is why, this is where we are making mistakes. We are not writing the answers completely. We are just writing it abruptly, or like half answers are being written. Okay, please don't forget to mention the side of the things, even in your x-ray questions. For example, Colles fracture, people are not writing which side is broken. Understood? Even like I have seen many of you guys, Colles fracture or Smith's fracture, they're just writing fracture of distal radius. That's it. Even a layman can see the X-ray and tell you that it's a fracture. So what is the difference between you and a layman? So describe the X-ray appropriately. Describe starting with side, which side of the limb the X-ray is off. Okay? Start with the side and other things. Then angulations, whatever you want to write, but please describe the X-ray completely. Okay, and then next thing we are if you are stuck in a question, you people are thinking like consultants. You think you are the supreme being on this planet and you don't write to call for help. Always we are making these mistakes. You think you are a consultant, you think you are the supreme being, and you are not asking for help. Okay, think like a junior always, and if wherever appropriate you have to write call for help, or call your senior ED physician, or call if it is in airway management, call for anesthetist, call for help. Don't always think you are a consultant. You are a junior in this exam. You might be a consultant at your workplace, but in this exam you should think like a junior. One more mistake what we are doing is we are taking a lot of time for a single question, and we are losing time eventually, and we are losing on the questions which are easy at the end. We are unable to attempt some questions which are there in the end. So I want you to like skip the question if it is taking too much time and come back to it later. This is what I did in my exam. The scenarios, the questions which were taking me a second read of the scenario, I skipped them and came back later. Okay, so try not to waste time behind a question. And finally, you are jumping to the diagnosis. When I have seen many people, when they are reading the scenario, they become biased. They formulate a diagnosis and they don't read the whole scenario completely, though the stems are asking something different which are not even relevant to scenario sometimes. Okay, so be careful. Don't directly jump to the diagnosis after reading 2 to 3 lines of a scenario. Read the scenario completely and then go for your answer, please. Okay. Okay, the solutions are pretty simple. I want you to think like a junior. What would you do if you are a junior of the department? Like, start with call for help. Okay, read the whole stem and question carefully. I want you to read the questions carefully, because many of times As I said, airway is taken care of, breathing is taken care of. The thing next thing they will be asking for you is to concentrate on circulation, and you guys again start with your airway breathing. Do you think if I am the examiner, if you are the examiner, will you give marks for that? No, right? So I want you to read the questions carefully and then write your answers. So before attempting, see what already has been done in the scenario and then answer. This is very important. See, if you write the right answer also, but you have written something nonsense in the starting, and even if you have written the things which are already been done to the patient in the starting, and you have written the right answer at the bottom, I will not give marks for that. Many of you people are doing in the mocks also, people have written the correct answers, but they have written the correct answers as the third or fourth point, which will not be considered at all by the examiner. And we feel that we have written everything right and we blame the college to be biased, right? So be careful. Don't write what has been already done in the question, and don't write unnecessary points. Just stick to your bullet points. Don't try to describe the whole thing. Keep it short, simple, sweet. Examiners don't have time and patience to read your bloody details. Okay? Write the answers completely. I don't want you guys to write half answers. No abbreviations at all. No half answers. As I said, write it completely. If it is a fracture, I want you to write the side, the place, the displacement, everything with your angulations. Everything has to be there. And then write your diagnosis. Just directly don't jump to your diagnosis. If it is a Colles fracture, I want, if at all they ask you the diagnosis as well, please, if they ask diagnosis also, please try to describe the x-ray and then write your diagnosis. Okay, whatever might be the question, if the question asks you the diagnosis or the question asks you the abnormalities, I want you guys to write the description of the x-ray and then write your diagnosis. That is the safest approach. Okay, then write as you write in your case sheet. This is simple advice I want you to follow. Do you write ABCD approach in your case sheets? No, right? You write what you want to give and how much you want to give in your case sheets. So please follow that. Write best answers first. This is the most important point. This is the point I have just now added. In your mocks, people have written right answers, but at the bottom they have written nonsense things in the starting of the answer and have written the actual things at the bottom. That will not fetch you marks. Those right answers will not be considered and you will get a 0. Please write your best answers first. Being Asians, we like to keep the best things at the last. I know we all Asians do that. We like to keep the best thing at the last. Please do not follow this pattern in your examination. I want you to keep your best things at first. And also, if they are asking 2 points, write 2 points. Why you want to waste your time writing the third point? Even if your third point is right, they will not consider the third point. And college nowadays are being specific, and they're being specific of how many points they want. So see, read the stems also carefully, like how many points they want. Okay. If you are stuck in a question, think as if the patient is right in front of you. Okay, think, if you're stuck in a question, what would you do if the patient is right in front of you? Okay, if you're stuck in a question. And the final point I want is, never forget or don't hesitate to take help. This doesn't mean to take help in the examination. Okay, this means to remember to call for help in your answer, right? Otherwise, later on, you guys will cheat in the examination and get caught, and then you will tell, "Arey, Dr. Rishad told, don't hesitate to take help." This point doesn't mean to take help in the examination. This, what I want to emphasize here is, wherever relevant, you write, call for help. It could be either your ED physician, It either could be your referral, specialist referral. It could either be an anesthetist for your difficult airway. Okay, please remember those things. Okay, now many of you guys, as I said, management questions are going wrong. People are writing some nonsense in the paper. See, management questions, I don't want you guys to write ABCD approach on paper. Please, repeatedly I'm telling you. If at all, when you're writing, you are getting the answer as ABCD, just step back and think once again and see where you're going wrong, because as I told, some components of your ABCD will already be done, and I don't want you to repeat what has already been given in the scenario. Please do not write ABCD approach. I've highlighted it in red. Okay, write like you're going to write on your case sheet. Okay, what should your management questions have? Try to avoid writing investigations in your management questions. Many examiners do not like investigations in your management questions. Okay? I want you to give I want you to write these things, like management questions should consist of your treatment. What is your treatment? What do you do in ER? You don't do much things. You give analgesia, you give IV fluids, what specific drugs you want to give. If it is a wound question, dressings, closure, what closure you want, primary or delayed closure, you want a steri-strip closure, decide, write that. You have TT prophylaxis, you have antibiotic prophylaxis, you have dressings if it is a wound. If it is a surgical question, you have nil paroral, you have NG tube, and etc. And your management question, your answer should consist of a disposition plan, whether you're going to discharge this patient or admit this patient. If you are going to admit this patient, what referral are you going to give? What specialist referral are you going to give? Many people forget to write referrals. As I said, you are not the supreme beings of this planet. You have to give a specialist referral if you are admitting the patient. So decide, if you are admitting the patient, give what specialty referral you want to give. Okay, if you are going to discharge the patient, what follow up advice and what advice would you give? For example, if it is a wound question, what right I would I would ask them to follow up with the GP and give a wound care advice. If it is a head injury patient, head injury advice. If it is an epistaxis patient, epistaxis advice. Okay, if it is a febrile child, fever advice. If you are discharging the patient, write relevant follow-up and advice you will give to manage the condition. If you are admitting the patient, write this what specialty you are going to admit. So these are the things I want in the management questions. And I said next step and next management are two different entities. Next step is single one thing, next management is two to three things. Your management should consist of these things. Okay, try to avoid writing investigations, though the college paper says that you can write the most appropriate investigation, but I would say try avoid writing investigations. Okay, how do I approach? This is what I made on a piece of paper before going to exam. So what approach I followed was, I read the stems first, then I read the trunk. Trunk is the scenario. Read the stems first, then the trunk. Then just before answering, I just went back to the scenario and saw what has already been done to the patient. Okay, then I wrote my answer. Okay, for example, I'll give you a simple example. In my initial attempts, there was a question of tension pneumothorax. I saw the picture and I saw the stem first. The stem read, what is your next step? And when I saw the picture and I saw the stem, I formulated my answer, and the answer what I got was needle decompression. I was happy. Oh, I know this answer, but I got a zero. because somewhere in the scenario it has already been written that your junior has performed a needle decompression. So your next step would be an ICD, right? So be careful. Just see what has been done. Okay. Picture questions. People are making a mess out of picture questions. College is asking you to write simple things. What is the abnormality in the picture? People are trying to make it so much complicated, and hence they're losing marks. Write the most obvious findings. For example, there was a question of globe rupture last time, ophthalmology question. They asked what is the abnormality of the picture. I simply wrote irregular iris and ruptured cornea. People went ahead and wrote some nonsense things and eventually got a zero. Please write the most obvious findings. College is not trying to trick you. Write the obvious findings and do not forget to write the side. As I said before, write side abnormalities seen, then write your diagnosis. As I said, all picture questions should consist of your abnormalities, then your diagnosis. Please. And also, don't blindly copy the answers from the question banks. Use your logic and write what is appropriate to your scenario. The question banks are there to guide you. They are not there. The answers what they have given should not blindly be copy pasted from them and write those things in your paper. Use your logic and use your scenario and then write. Extract your answer from the information given in the question banks. Just don't blindly go ahead and copy paste it from there. Use your logic. Avoid writing doses if you are not sure. Okay, many of the questions are like what drug you will give. Okay, if they have specified you to write dose, you have to write the dose. If they don't specify to write the dose, if you know the dose and if you're sure of the dose, then write the dose. Otherwise, avoid writing the dose. For example, if they ask a question of a cardiac arrest, they give you a PA and they tell what is the next drug you give, and they just write what is the next drug. If I write adrenaline, the examiner will give me marks. If I am sure of the dose, if I write adrenaline 1 mg, 1 is to 1000, sorry, 1 is to 10,000, then I am sure of it, right? Then I will get marks. But if I write adrenaline and if I write 2 mg, 1 is to 10,000, then examiner will not give me a single mark, because though I wrote adrenaline, I'm giving a wrong impression to the examiner. So if you are not sure of the dose, please do not write. Okay, don't waste too much time on a question. As I said before, what I did was, if the question is taking me a second read of it, I skipped the question and came back to it later. But make sure you come back to it later. Okay, don't waste too much time on a single question, because what I felt was the questions in the end are much easier and straightforward than the questions at the start. Okay, so please do not waste time on the questions which you're not getting it immediately. Skip, come back later. Okay, and as Sajjad sir say, every 30 minutes review yourself. Review yourself means just see in which question you are there. You should be able to finish 11 questions in 30 minutes. This should be your target. Okay, at least of 11 questions in 30 minutes. Every 30 minutes just see where you are at your question number, and from there you can change your speed, whether to gain speed or go a little slower. Okay, please review yourself every 30 minutes. And yeah, the most important, attempt all questions. I want you to attempt all questions, write neatly. Many of you guys are writing the right things, but if the examiner cannot understand what you are writing, they will not give you marks. Because imagine an examiner correcting the papers the whole day, and just before going home he is frustrated. He does not have the patience to try and read what you have written. Okay, please write legibly, please write neatly. Okay, even in your practice I want you guys to write neatly. It is a legal binding to the doctors to write neatly. Okay, please write neatly. Okay, that was enough of tips to write the answers. Now let's move on to, like, I have jotted down some of the things. You can regard these things as common topics or a checklist for your last 2 to 3 days of your preparation. Okay, this is what I could come up with. There are many other things, but I want you to at least know these things before going to the battle. Okay, so let's start. Okay, anesthesia, pain management is the most important thing in adults and children. Pain management. In the exam, please do not follow the pain ladder. Follow your pain score. Okay, pain ladder is just for your knowledge. If your pain score is 8 or 9, do you give start from paracetamol? No, right? You directly jump to your morphine. So try to give your analgesia or pain management things according to the score. Okay, according to the score, write your appropriate pain management. If they don't give you the score, just see what this condition, or what, if it is a fracture, what do you think the score can be, and appropriately you write your pain management. Okay, it's pain management is a very common question. We tend to write analgesia for almost all questions. So please just don't write analgesia. Write what you're going to give to the patient. In your case sheet, you just don't write analgesia. You write what you want to give. Right? Please be precise. Okay. Next common question is procedural sedation. Procedural sedation. People should know the difference between the doses of either propofol or ketamine. The doses of induction in RSI are different to what you use in procedural sedation. For example, if you use 2 mg per kg of ketamine in your induction, your procedural sedation is almost half of the dose of induction agent. Your procedural sedation ketamine dose is 1 mg per kg IV. Your induction agent is 2 mg per kg IV in ketamine. Please, there is a difference in induction and procedural sedation doses. You should know your difficult airway, that is Das algorithm, local anesthesia toxicity. Fascia iliaca block can be asked as a common question, and stop before you block can be asked. And there is one more potential question for fascia iliaca block is, for how much time will you monitor post fascia iliaca block? Because recently NHS have produced a guideline, because I think there was a death in the UK post fascia iliaca block. So your answer should be post procedure 5 minute, 10 minute, 15 minute, 30 minute and 1 hour. Post fascia iliaca block, you monitor after 5 minute post procedure, then 10 minute post procedure, then 15 minute post procedure, then 30 minute post procedure, and then 1 hour post procedure. Okay, other blocks are very unlikely they are going to ask you about the procedure of the blocks. Apart from fascia iliaca block, they might ask you uncommon, but as I said, you have to be prepared for the bouncers. You cannot avoid bouncers. If they don't give you bouncers, you will not respect the examination, sorry. So you just subconsciously read some of the blocks, but facial like a block is a potential question. If the question comes, what pain options other than morphine? Think of some blocks. Think of some blocks or some epidural anesthesia. Think of, for example, there was a question of flail chest. The second question of the flail chest was, what two other options of pain management you have? So think of blocks. You have intercostal nerve block and you have serratus anterior block. These are the two blocks you can give in a flail chest: intercostal nerve block and serratus anterior block. Then the third answer was of flail chest last time was, what is the surgical option of your pain management? So still there are a lot of controversies regarding that question. Some people are saying it is a surgical fixation of the ribs. Some people are saying no, it is the uh, epidural like epidural pain management. So I do not know what to write in that. I think only Dr. Sajjad sir can help you with that. So whenever they ask other than like not other than morphine, or you feel like in the question already morphine has been given and repeated doses have been given and they have asked something beyond, if they want to ask something beyond morphine, think of blocks, especially in trauma patients. And if it is sickle cell anemia or sickle cell crisis patient, think of epidural. Okay, anesthesia, initial ventilatory settings are very important. Please formulate initial ventilatory settings. What I think was, what I did was, I think in exam they show you some knobs, which of some knobs are there in the picture. Please don't go by the knobs. Formulate your answer before you go to the exam. Well, this is how I formulated. If it is initial ventilatory setting questions, I'm going to write volume control, how much tidal volume I want to give, how much respiratory rate I want to keep. Okay, formulate your answer before going to the exam. This is what I did. Mode, volume control. Tidal volume 6 to 8 ml per kg. Respiratory rate 10 to 12 per minute. PEEP 5. Okay. FiO2 100%, titrate it down to keep more than 94% saturations. You can also write I by E ratio. Okay, don't go by the knobs and get confused. Formulate your answer before you go to the exam and stick to it. They can ask you lung protective mechanisms. If the scenario is saying the picture of ARDS or lung, they specifically ask you for lung protective mechanisms, you have to be precise. Lung protective mechanisms are directed to keep the tidal volume at 6 ml per kg. Okay, and peak plateau less than 30 centimeters of water. This is to keep, and yeah, also permissive hypercapnia. This usually is done in ARDS picture to avoid barotrauma, volutrauma and biotrauma. Okay, oxygen calculation for transport. I would advise you to write the formula and move on. Okay, then you have a potential question of Mallampatti views and Cormac and Lahane. Sorry, I couldn't write here, I missed it. Mallampatti views and Cormac and Lahane. Okay, remember to call for help if you have a scenario of difficult airway. Remember these three things: call for help, that is your anesthetist; call for difficult airway trolley; call for surgical airway trolley. If the scenario is showing a picture of difficult airway, these three things should come to your mind: call for help, call for your airway trolley. Difficult airway trolley, call for your surgical airway trolley. A potential question is tube dislodgement. It could be either tracheostomy, endotracheal. So there is the algorithm of this. Please go through that one day before you go to the examination, and please, I want you to go down the algorithm. Don't go up the algorithm. For example, the question last time was, how will you like after attach, like in the first question you have attached the water circuit. The answer was like attach water circuit and all. The second question, how will you confirm tube dislodgement? So answer there should have been no normal ETCO2 monitoring, no chest rise, no spontaneous movement of the water circuit. But people went back the algorithm, and again they have written hypoxia, they have written cardiovascular instability and all. You are going up the algorithm. Please do not go up the algorithm, go down. When you have written water circuit, it is, if they ask what is the next thing, you should go down the algorithm. You should not go the algorithm in reverse, be it any algorithm. Try to go down the scenario, not past in the scenario. Okay. Resuscitation. Resuscitation, I want you guys to read. I think more like you should have been familiar with it by now. ALS with modification for special circumstances like hypothermia, pregnancy. There are some ALS modifications. I want you to read it. Okay, and also as I said in the course, that I want you to answer the like current joules, how much joules are going to use as per the ALS guidelines, not ACLS guidelines, because many examiners are not giving marks if you write according to ACLS. Okay, please write according to ALS guidelines. There is no much difference. There are very minor difference. It will take you 10 minutes only to see that. Go to resus.org.uk, you will find it there. Okay, the potential question is also anaphylaxis versus angioedema, differential points in history. Please, it's a potential question, it has been asked before. Go through your sepsis bundles. Okay, let's move ahead. Procedures. See, procedures, what they are concentrating on these days are like what I have seen in the exams and questions. What I've seen in exam and questions, they are asking things like how to avoid complications, how to troubleshoot, indications, contraindications, and major complications. For every procedure, you need to know these 5 things. For example, like last time there was like a question on ascitic tap. The question was, what is the complication and how can you avoid it? So for every procedure, I want you to at least know I want you to at least know 3 major complications and how you can avoid them. Okay, I want you to know the indications. I think everyone knows it by now, and I want you to know the contraindication and at least one absolute for every procedure. Absolute contraindication is more important than the relative contraindications, right? So, and yeah, and also how would you troubleshoot if you have a problem post procedure? For example, questions of arterial line troubleshooting are commonly asked. So I want you to know how would you troubleshoot procedures. Post procedure, how will you troubleshoot if you have a problem? Okay, the most commonly asked procedures are arterial line, chest drain, Seldinger or open, ascitic tap, central venous access, IO, pacing or defibrillation, endotracheal intubation. Since we are at pacing, there was a question last time. There was a rhythm. There was a rhythm showing pacing. Like there was a scenario like pacing has been started by a junior or by a nurse, and they get a strip to you, a patient with history of syncope, in the strip you see the QRS complexes are somewhere and the pacing rhythm is somewhere. There is no correlation between them. When there is no correlation between the pacing rhythm and the QRS complex, that means there is no electrical capture. Practically, every pacing rhythm, you know how the pacing rhythm is, it is just like a straight line. Every straight line of a pacing rhythm should be followed by a QRS. If you're not getting that, that means you're not getting an electrical capture. So the question first was, what is your rhythm? The answer should have been, it is a pacing rhythm without electrical and mechanical capture. The second question was, what would you do now? The answer for that was, increase the current till you get an electrical and mechanical capture. The third question was, what do you do if the above procedure fails in your ER department? They were very precise. What would you do in your ER department? Many of you wrote transvenous pacing and all. You don't do that in your ER department. So there they wanted to see how will you troubleshoot your pacing. So your answer should have been, check pad positions, consider it placing anterior-posteriorly, and then give your cardiology referral. So they wanted to see how are you going to troubleshoot your procedure, what you have done. They didn't want you to write transvenous pacing. Okay. And also, yeah, endotracheal intubation, anything can be asked from that. Okay, common competencies, what I feel is they can ask you tetanus prophylaxis, needle stick injury, warfarin. Okay, warfarin in INR has not been asked last time. Very likely they are going to ask this time. They are going to give some scenario. Most common scenario they give you some elderly man on warfarin recently had an respiratory tract infection. Some antibiotics started by his GP. So this scenario can come up, and like how would you manage the INR? Please read that carefully. Yeah, wound care is a common question being asked. Wound care, how would you like, wound care is a common competency. Like I said, think of TT prophylaxis, antibiotic prophylaxis, dressings, closure, and advice. This is your wound care. How would you close it? Whether you want primary delayed, dressings, TT prophylaxis, antibiotic prophylaxis, advice, and yeah, think of your district nurse as well for your dressing change, please. Okay. Yeah, history taking. Last time there was a history taking of non-accidental injury or domestic violence. Last time, history taking sexual history is also important. There was a question on advanced directives last time. Okay, as I remember, the question was, you had a patient in which you have established that he is lacking mental capacity, and then they asked you that how would you, what would you, I think the question read something like this, like what would you see, or like you like some from some way you have come to know he has an advanced directive, and what would you do next? So people again went and they have written, check for mental capacity, though the scenario is telling that you have established that he is lacking mental capacity. You have people, majority of the people have written to check mental capacity, but the answer there was to see the validity of your advanced directives. Okay, how would you, the question they wanted to ask, how will you assess for validity of advanced directive? And people have written, like as I said, go down the scenario, not up. People have gone up, and again they have written to check for mental capacity, so be careful. Yeah, consent is a very common question that is been asking. You should know, like, who can consent. The patient himself can consent. If the patient lacking capacity, it is the doctor who to decide. If the patient is lacking capacity, think of whether he has advanced directives, whether he have an LPA, that is your lasting power of attorney. If you are unsure, treat in patient's best interest. If only lacking capacity, if the patient is having capacity and if he is not consenting, even if the patient is dying, uh, you have to leave him. You can only go against his wishes if he is registered with some mental health, is having some mental health issues in the past, only then you can go against his wishes. Otherwise, if he is having capacity and no past history of any mental health issues, then even if he is dying, you cannot do anything. And also consent, young people less than 16 years can consent for the treatment. They cannot refuse the treatment. People less than 16 years of age can consent for the treatment. We have to discuss with them. They can say yes for the treatment, but they cannot refuse the treatment if it is a life threatening situation. Okay, there is a, and also yeah, consent also you have to just have a look on Gillick competencies. Okay, then LPA, DVLA is a very potential question. DVLA is asked lot of times. DVLA, when do you inform DVLA, when do you don't inform DVLA? And questions can be asked like, in spite of you advising patient not to drive, you have seen him driving, so what do you do? So you have to write that I would, if you see the patient is driving, so you should say that I would inform the patient that I'm going to inform the DVLA, and then send a written letter to the patient that you have informed the DVLA. Okay. Next, alcohol. What is harmful drinking? What is hazardous drinking? There is a difference between them. Now, what advice you would like to give, and what is your allowance? Okay. Never events. There was a question last time of an accidental insulin overdose. What is that event called? That event is called never event. There are a lot of never events for the hospital. What I could come down, which is relevant to emergency department, is insulin overdose, wrong potassium correction, okay, patient fall from the stretcher, and wrong side block, nerve block or whatever, wrong side block are relevant never events for the emergency department. Know these things. This event is called never event. Remember, any patient with a wound, I think there was a question like what two specialties other than medical specialties you want to refer to. A patient, I think, was a diabetic foot or a wound, I don't remember. Those answers were district nurse for your dressing change and occupational therapist to help for day-to-day activities, right? These are the two things for common competency. This, I think something from this is going to come up for the exam. Okay, for surgical, I want you to go through this as a checklist. Dissection, aneurysm, obstruction, volvulus is going to come in the examination. Perforation, I think, yeah, volvulus, I wanted to mention the one thing that the question, I think, two exam back, there was a question on volvulus, like what is the immediate thing that can decrease the symptoms. Many people wrote flatus tube. Please do not write flatus tube, just write nasogastric tube, no flatus tube, please. Okay, you can have perforation, you can have renal colic, acute urinary retention. There was a question on acute on chronic urinary retention, like in March. A big bladder, if you can remember, if you guys can remember, there was an X-ray with a big bladder, and recently the patient was started on by some drug by a GP for his bedwetting. So the diagnosis for that was acute on chronic retention. And what are the complications are, if you catheterize, you might have bleeding, you might have dyselectrolytemia like hyponatremia, because of diuresis. Okay. Okay, torsion is another important. Testicular torsion is a clinical diagnosis in ER. You only get an ultrasound Doppler after liaising with the urologist. You don't decide yourself. Okay. Orbital, from ophthalmology, orbital cellulitis is going to come up this time. CRVO, CRAO can come. Globe rupture was there in the last exam, so it might come this exam. Glaucoma, yes, glaucoma. Remember, all asthma medications cause exacerbation of glaucoma. That is your salbutamol, ipratropium bromide, or corticosteroids causes exacerbation of glaucoma. Uveitis, sorry, I spelled it wrong here. Uveitis can come up in the examination. Okay, okay, epistaxis. You should all know the management of epistaxis by now. Especially advice, if you're discharging the patient, what advice you would give. Please go through all advices before you go to the exam. Any kind of foreign body can come up. Okay, now as we are going into ENT, as I said, BPPV versus central vertigo can come up. Vestibular neuritis, trigeminal neuralgia, temporal arteritis. There was a question in which people got confused between trigeminal neuralgia and temporal arteritis. The clue here is if the patient in the scenario, if in the scenario they are giving the patient is having polymyalgia rheumatica, then your answer is temporal arteritis. Okay, so be careful. Then orbital blowout can come. C for teardrop sign and your eyebrow sign. Then a tripod fracture can come. Lee-Ford's fractures can come, and there was a bouncer last time, dental fracture. Please go through that. That was a bouncer last time, dental fracture. Okay, see, many things can come. These are the things what I could think of. So I want you guys to at least know these things. Okay, whenever you have an ECG, these are the things what you can think of. You can either have a long QT. Okay, you can have a question of Brugada. Your ECGs can be long QT, Brugada, trifascicular block, AV blocks, ACS, hypokalemia with U waves. This was a question in March. Hypothermia or Osborne waves, overdose of TC or digoxin. Digoxin, you can have reverse tick signs. Okay. AF and SVT, especially they can ask you doses of like synchronized cardioversion. Please go through your ALS algorithm for the dose of joules. Pacing rhythm, I just discussed. Pacing rhythm, WPW, very uncommon they might ask, but it is a potential question. VT, VF and torsades. They can give you a torsades uh, and ask you what is the rhythm. You can write polymorphic VT or torsades. Then they can ask you the second thing, what they can ask you, what after reverting, what rhythm can you see. So they can, in one question they can ask you torsades and long QT as well. Okay, be careful. So these are the potential ECG questions what they can ask, and I want you to answer your ECG questions in a systematic way. Even if they ask, for example, if they ask, give you a Brugada ECG, and they tell you to, if they directly tell you to ask, like write the diagnosis, still I want you to describe the ECG and then write the diagnosis. Please formulate a plan before you attempt picture question. Write the abnormalities, then write the diagnosis. Irrelevant. Like if they ask for the diagnosis, also describe the ECG and write the diagnosis, please, to be on a safer side. Ultrasound images, central line, IGV was asked last time. Interception is a potential ultrasound image, like donut sign, or you can call it as a target sign. Okay, fast scan, you can get an image of fast scan. Though ultrasound is not in our curriculum, but central line ultrasound image did come last time, and the question was was the most controversial question in central line was why you would like move the probe in a longitudinal direction. The answer for that was to confirm the placement after putting the line. Okay, it was, the answer should have been to confirm the placement after putting the line. Okay, please. X-ray. Whenever you have an X-ray, think of pneumonia, pneumothorax, rib fractures or flail chest. Air under the diaphragm was there. There was a X-ray, like I remember it because I got it wrong. There was an X-ray in the exam, I think in last September, not September 2018, but I'm talking about September 2017. Everything was looking normal, but when you think the X-ray looks normal, see at the subcutaneous tissues around, you will see something there. Okay, will see something black there. You will see subcutaneous emphysema, and see the scenario: young patient with vomiting, with chest pain. I think it is something Mackerel's triad. Yeah, vomiting, chest pain, subcutaneous emphysema is the triad. So when everything looks normal, you think everything is normal, then look at the soft tissues. Don't forget to look at the soft tissues when you think everything is normal. It can be a Boerhaave syndrome. Okay, you can have a PT. Very unlikely they'll give you a pulmonary embolism X-ray. Remember about Hampton's hump and Westermarck sign. Okay, very unlikely they will ask, but they can ask. Usually in pulmonary embolism you will have a normal X-ray, but sometimes in 2 to 5% of people you will have Hampton's hump and a Westermarck sign. I don't think anything else will come up in the chest X-ray apart from these things. Other pictures, you had a picture of magnet last time. What is the mechanism of injury? Two magnets can cause ischemia of the bowel. How is that? Is the two section of the intestine can be attached because of the magnets and cause ischemia. Okay, an obstruction as well. You can have a nasal foreign body. You can have any dermatology question. Kawasaki versus Scarlett. Please try to get the difference between them. They are very similar. So for Kawasaki, there is a criteria of fever of more than 5 days, at least of 5 days, with 5 of the things. So if that is not matching, it is a scarlet fever. There is a difference. There was a question in March and many people got it wrong. Please go through it once again. Hand injury or hand bite is very common question. How will you see? As I said previously in my previous slides, injury, any wound management question should have your closure, whether you want to close it or not, dressings, TT prophylaxis, antibiotic prophylaxis, follow up. Okay, pre-tibal lacerations, as you know, steri-strapes, pre-tibal lacerations. Reason for poor healing can be: one, patient is on steroids, patient is diabetic, and very less subcutaneous tissue over the tibial region, poor blood supply. Diabetic foot is going to come in the exam. How will you manage? People are getting wrong most of the times. Okay, please be careful. Okay, orbital blood fracture, tripod fracture, as I said before. Trimalleolar fracture is a potential question. Trimalleolar fracture. So I remember there was a question. They only gave you a AP view of fracture, and you could see that both the malleolus are broken. So they asked, the question was what additional view you want. It was like you wanted a lateral view to rule out trimalleolar fracture. Okay, winging of scapula, as I said, please do not forget to mention the side. One thing is that any anatomy question can come up in the examination. I have seen that they are like winging of scapula or something, they can ask some anatomy questions. So be careful with that. Pelvis X-ray, it can be SUFI, Perthes, or it can be femoral head, sorry, neck of femur fracture. Okay, you can have a shoulder dislocation, anterior posterior. Many of you guys are getting confused. If it is a post in light bulb sign is seen only in a posterior dislocation, not anterior. Please be careful. Posterior dislocation of shoulder is a light bulb sign. Pediatrics, anything can be asked from pediatrics, but these are important. Please read about Brui. Brui is very hot these days. Please read about Brui. DKA, dehydration, of course. I think people have become experts in DKA because that is the most sorted out topic, if not in the exam, but in our discussions. Okay, febrile seizures or any seizure in child, limping child, think of a limping child, of course septic arthritis, think of Koch's criteria. Sufi, Perthy, there was a question on osteosarcoma. I think the question was of a child having like a simple injury and come to your emergency, like a limping followed by a simple injury, and they gave an x-ray of knee. Many people got it wrong. It was an Ewing sarcoma or osteosarcoma. So just read about it. Okay, toddler's fracture, Osgood Schlatter, Salter Harris. Please go through that. Duct dependent lesions, Kawasaki, as I said, Kawasaki, scarlet, measles, complex spots, my favorite questions. Fever in children, you should know your traffic light. Meningococcal disease and HSP. HSP was there in the last exam. Asthma, NALS, PALS, NAI, and accidental poisoning. There was a question on accidental poisoning of, I think, carbon monoxide poisoning in March. Okay, NAI, they might ask you like history, what history would suggest of NAI, or what examination, like what are your examination findings of NAI, what history findings of NAI. So there's a difference between history findings and examination findings. Trauma, as I said, trauma is a very big subject. Anything and everything can be asked from trauma. But important things are secondary head injury prevention, indications of CT brain in trauma, indication of neurosurgery and CT surgery referrals, indications to burns, indication to burns unit referral, indications of laparotomy. All, like they might ask you all 6 indications. Okay, fractures, starting from head to toe, anything can come up, but important things in fractures are orbital fracture, tripod fracture, hangman's fracture, Jefferson's fracture. I think subluxation and pseudo subluxation of cervical spine. I think there was a question of a child, I think in March, in which they wanted to see whether you know of pseudo subluxation in like people, in children less than, like 40% of children in less than 7 years of age, they have a pseudo subluxation of C2 over C3. So there was a question on that in March. Clay-Chauvel's is a potential question. Central cord syndrome is going to be there in your examination. Shivora is also going to be there in your examination. So if there is an elderly patient with some neurological deficit more in the upper limbs and the X-ray is normal, it is a central cord syndrome. If it is a child with normal X-ray and neurological symptoms, it is a Shivora. Adult with normal X-ray is central cord syndrome. Child with normal X-ray of spine, cervical spine, is Shivora. Shivora is spinal cord injury without radiological abnormality, full form. Then you can have a chance fracture, L1 fracture. Think of abdominal injury also when you have a chance fracture, L1 fracture. There was a wedge compression fracture, I forgot to mention here, wedge compression fracture. Okay. Shoulder dislocation, elbow dislocation. There was a question on elbow dislocation, so you should know, like there was a question on how would you reduce elbow dislocation. Just go through that once. Montegia, Galeazes. Okay, Colles, Smiths and Bartons. People are very confused with these uh, fractures. All of these are distal radial fractures. Just do not write distal radial fractures. Okay, Colles. So the confusion is about the angulation. In Colles fracture, the distal end is displaced dorsally. Colles, distal end of radial fracture and distal component of fracture is displaced dorsally. In Smiths, it is displaced ventrally. But if there is an intra-articular fracture, be it Colles or Smiths, whether be it distal displacements or dorsal displacement, if there is an intra-articular connection, then it becomes a Barton. It is no more a Colles or Smiths. It is a Barton. Okay. Bennett's and Rolando fracture, important. Gamekeeper's thumb, boxer's fracture. Lisfranc is going to be there in your examination. Jones fracture. Knee dislocation is also important. Knee dislocation is important because you will have to admit all patients with knee dislocation for observation because of neurovascular very high possibility of vascular compromise. Okay, and also you measure ankle brachial index in your knee post reduction of knee dislocation. So I want you guys to read about indications of ankle brachial index in your emergency department. At least you should know three conditions. One is knee dislocation. One is, I think, to see the vascular like I don't know, like just go through that. I don't remember. Just I want you to know three indications of ankle brachial index, like to see for any vascular insufficient. I think, yeah, it is knee dislocations. It is to see for vascular insufficiency in lower limbs when you have a chronic ulcer. And one more, like just go through the text. I think it is there in Musa Isa. Okay. Then ankle dislocation or subtalar dislocation. There was a question in that, as I remember. So the question was, when do you like immediately reduce it? So I think the possible answers could be, one is when you have a neurovascular compromise, or when you have severe pain, or when you have skin tenting. Skin tenting means the skin is getting stretched so much you feel that if you do not relocate it immediately, it might become an open fracture. Okay, they can give you a fast scan. Next, they can give you a fast scan image and tell you what is it, ask you what is it. Okay, next, toxicology. Paracetamol, salicylate, carbon monoxide. Whenever they ask you a carbon monoxide with high lactate level, give you high lactate levels, think of cyanide. TCA, neuroleptic malignant syndrome, serotonin, lithium, digoxin, iron, and the last time there was a question on acute dystonic reactions. Okay, acute dystonic reactions, and there was a picture of oculogyric crisis. So please read about that. Obs and gynec, important things are ectopic pregnancy, PID. PID, please just have a point, read a point or two about vaginal candidiasis, trichomonas vaginalis. There was a question on chancroid in last September 2017. Chancroid, syphilis and bacterial vaginosis. Read a point or two about this. Okay, STDs. Whenever you think the patient has STD, don't forget to refer to a gum clinic. Everyone, majority of us forget referrals. Please remember referral in your managements. Miscarriage and antepartum hemorrhage. There is a question. There was a question of like a 20-year-old female patient with 28 weeks of pregnancy, the first question with spontaneous bleeding, the first question was, what is your diagnosis? Second question was, the patient suddenly started having sweating and went into hypotension. What is your diagnosis? Third was, what would you do now? So the majority of you guys have written spontaneous abortion as first. What is your diagnosis? Second, when question was patient went into hypotension with sweating, people wrote cervical shock. Third question was, what will you do now? People wrote to remove the products of conception with the sponsorships, right? But the clue here is the gestational age. Spontaneous abortion only happens in less than 24 weeks. Antepartum hemorrhage happens more than 24 weeks. So they go by the weeks of gestation. A bleeding pregnant woman less than 24 weeks is abortion. More than 24 weeks is antepartum hemorrhage. It can be abruptio placentae, placenta previa. Okay, this, don't get confused. So the answer there was concealed. It was a concealed hemorrhage of abruptio placentae. Emergency contraception can be asked. Preeclampsia, eclampsia can be asked. Okay, these are the potential topics what can be asked in the examination. Next, the most important checklist is to maintain your composure, and you also need good luck. Yeah, you know why you need luck and composure? Many of you guys are becoming anxious and writing wrong answers. And luck you need because you need to get right points at the right time. Okay, and also, yeah, of course, you should be prepared. You need luck for the bouncer questions as well. Please maintain your composure throughout your examination. And good. Yeah, finally guys, I want to give some advice. Now you guys are prepared for the battle. Yeah, I know you guys are damn prepared for the battle. You have all your guns and your weapons ready in place. So relax now. Stop cramming up new concepts. Stop reading new things. Don't try to read new things and get confused. Don't try to add new resources to your preparation. Stick of what you know already. Like, create your own checklist or just checklist which I have given in this video. Just try to follow for last 2 to 3 days. I don't want you to mug up everything again. Just go through the things which you are not comfortable with. Sleep good, take good night's sleep daily before the examination, and spend some time with your family. Yeah, it helps to like bust your stress when you spend time with your family. And yeah, guys, try avoiding having coffee on your day of examination because it acts like a diuretic and you'll waste time peeing during your examination. Please try avoiding having coffee. Have a good breakfast, but don't drink coffee or tea. Okay? I know you guys are going to pass this time. All of you guys are going to pass this time because if a person like me can do it, any of you, one of you can do it. I trust you guys. You are excellent doctors, excellent ER physician. You guys are going to pass this time, but that is not your target. You are going to nail this exam. You are going to destroy this exam this time. Okay? Destroy the exam, folks. Destroy the exam. Okay, thank you very much. These were my tips. I hope, like, I want a good party from each one of you guys after you pass the examination. Thank you.